we try to keep the needle tip at a wide bore needle. We usually use 14 gauge needle. We keep the needle here and insert the catheter, and catheter has to be just above that line crosses the clivus. Say 2 to 3 millimeter above this line. I'll just come to that. When we started, I think we started this procedure in 2010, when we started this patient that internationally, that Cook's PRPC kit used to be available, but that was not available in India. So we made some stopgap arrangement. We utilize this type of needle. This is the needle, 14 gauge needle. This needle is basically used for insertion of spinal cord stimulating lead. Okay? And we use this Fogarty 4-inch catheter for conduct of this. Nowadays, this kit is available. This is around 35 to 40,000 kit. It has got all the things and has a pressure monitor also. To start the procedure, I always take AP view first. And if you look at the AP, this is not the AP view. And AP view, I try to keep the petus part of temporal in the inferior part of the orbit. That is a true AP view. And I tilt for some interval till this, you can see this mandible, maxilla, and this is some mental arch. Unless you have this area, this is a bone-free area, then usually a 20 to 30 days submittal is more than adequate. And once you have that area, then you slightly have a oblique view. You rotate the C-arm ipsilaterally and have, the focus is always this. You can see this foramen ovale. It should be always, if you divide in 4 quadrants, this should be always in the upper quadrant. And as you can appreciate, in this area there is no bone. So you can simply use the tunnel view. You can after this, I always use 2 to 3 centimeter to the external angle, and I always use tunnel view. If my, especially in RF ablation, if I am planning to do ablation of V3, I always keep the needle lateral or middle if you are planning to use V2 or V3. And for PMBC, I will insert the needle in the middle of the foramen. Sometimes there is an article by Brown that says that if you take it's a true AP view. Now you can see the petus part of this both. If you appreciate the middle part of this, in middle aspect, there is slight dip in the petus part temporal. That's the area where Meckel's cave lies. If you keep the needle laterally, that means you are trying to ablate the V2. If in the middle of this, that means V2 or V3, or medially for V1. As you can appreciate, the tip of the needle is not crossing, not more than 2 or 3 millimeter above the foramen ovale, and direction of needle is the point where clivus joins the petus part of the temporal bone. After asserting that is my needle position is okay, I insert the catheter. Initially, we used to use that ureteric catheter to make a tunnel so that we can insert the catheter safely. But over a period of time, we found that there is no need of making any tunnel or channel. You can simply, most of the time, most of the patient, you can simply insert the Fogarty catheter. As you can see, the tip of the catheter is just 2 to 3 millimeters above the point where the clivus meets the petus part of temporal bone. These are balloon shapes of, once we have confirmed that my tip, balloon tip, this catheter tip position is okay, we try to inflate the balloon. We take 1 ml of radiocontrast material, and this has to be done by continuous fluoroscopy technique. Initial fixture done after starting the inflation with radiocontrast dye. This is Then ideal position is this. You can see that the nipple is coming out, and that shows that nipple is going towards the porous trigeminal. That's the ideal. That's the ideal position, so that you can have a good compression of the trigeminal ganglia. Coming to different pictures, if you overinflate the, you can have a dumbbell shape appearance, dumbbell application, and this is more or less ideal position for having ideal compression, pear shape appears. As I told you, that ideal position is this 2 to 3 meters above the